You got out of bed this morning and something felt off in a way you couldn't quite name. Maybe it was your joints. Maybe it was the fog behind your eyes that didn't lift with coffee the way it used to. Maybe it was a hot flash that showed up at a meeting for no reason. You've been noticing it for a while, and somewhere along the way, someone told you it was just menopause, just aging, just something to push through. Most women my age have been told that hormone therapy is dangerous, full stop. That advice isn't wrong for every situation, but it leaves out the one factor that changes the entire risk picture when you start it. And the gap between hormones are dangerous and hormones are dangerous at a certain age and time frame is the difference between a woman who suffered through symptoms for 2 decades unnecessarily and one who got real relief with a manageable risk. There is no revenue in a 15-minute visit to walk through 2 decades of shifting research, so let's do it here. Pharmaceutical companies that make non-hormonal alternatives have no particular interest in you revisiting a therapy that went out of fashion in 2002. And regulatory caution, once a warning label goes on a bottle, is slow to come back off even after the underlying science moves on. The most important thing on this list has nothing to do with a supplement or a diet change. It has to do with a single design detail in a government-funded study that, once corrected for, flipped decades of medical advice. Researchers at the Women's Health Initiative themselves went back into their own data and found that the story they told the world in 2002 was true for one group of women and largely wrong for another. I'll walk you through exactly what that means for you. Before we get into it, tell me in the comments how old you were when you first heard hormone therapy was dangerous, and whether that's shaped a decision you've made since. I read every comment and it tells me what to cover next. Let's start at the bottom of this list and work up to the finding that actually rewrote the guidelines. Number 5. Don't let this position fool you. This is the piece of the story that's been repeated in doctors' offices across the country for over 20 years, and almost nobody explains why it happened. In July 2002, the Women's Health Initiative halted its combined estrogen plus progestin trial early because the data showed increased risk of breast cancer, heart disease, stroke, and blood clots. The finding was real. It wasn't a typo, and it wasn't overturned. Women in that trial, on that specific combination, at that dosage, did face those increased risks. What most people were never told is who those women actually were. The average participant was in her early 60s, more than a decade past menopause, many enrolling into hormone therapy for the first time at an age when their arteries had already begun accumulating plaque. Think of it like restarting a car engine that's been sitting in a garage for 10 years versus one that's been running steadily the whole time. You don't pour in high-octane fuel and expect the same response from both. The 2002 headline didn't distinguish between those two engines. It just said hormones are risky, and an entire generation of women, doctors, and pharmacies absorbed that as a blanket rule rather than a rule about timing. Consider a patient, let's call her Diane, 68, who ran a small bakery 6 days a week and had managed her menopause symptoms with nothing but grit for years. Her previous doctor told her hormone therapy was permanently off the table because of the 2002 study. Full stop, no follow-up. What actually needed to happen was a real conversation about her specific age, her time since menopause, and her cardiovascular risk profile, not a blanket refusal based on a headline she'd heard once on the news. Tonight, if you're in Diane's position, the preparation isn't a pill, it's a piece of paper. Write down the date of your last period, your age, and any cardiovascular risk factors you know about. Cholesterol numbers, blood pressure readings, family history, because that's the actual data. A modern conversation about hormone therapy starts with, not fear from a headline 2 decades old. Pair that list with your last mammogram date because breast cancer risk is the other half of this conversation, and it moves on its own separate timeline from cardiovascular risk. This groundwork sets up everything else on this list, because every item that follows depends on knowing exactly where you sit on that timeline. Number 4. Most people assume hormone therapy is one thing, a single pill, a single risk profile. That belief is costing women options they don't know exist. The Women's Health Initiative actually ran two separate trials, not one: a combined estrogen plus progestin arm for women with a uterus and an estrogen alone arm for women who'd had a hysterectomy. A later reanalysis of that estrogen alone trial found that for women who started estrogen therapy at 50 to 59 years old, for every 37 women treated, one fewer experienced a major health event, including heart attack, stroke, hip fracture, or death over 13 years of follow-up. That's not a rounding error. That's a number needed to treat that most people have never heard, because it came out years after the panic headlines had already reshaped clinical practice. Think of estrogen and progestin like two ingredients in a recipe that got blamed together for a bad dish, when it turned out one ingredient was the problem and the other was fine on its own in the right hands. The reason age matters so much here connects to something called vascular aging, the gradual stiffening and plaque buildup in artery walls that accelerates after menopause due to loss of estrogen's protective effect on blood vessel lining. Healthy, more elastic arteries respond differently to estrogen than arteries that already carry years of accumulated damage, which is part of why the same hormone can look protective in one group and risky in another. Consider a patient, let's call her Renata, 54. A retired teacher who had a hysterectomy at 48 and had been managing hot flashes with nothing but a fan by her bed for 6 years. Her doctor had lumped her into the same no hormones ever category as everyone else, without distinguishing that she'd never needed progestin in the first place because she had no uterus to protect. Once that distinction was made clear and she and her doctor reviewed her actual risk factors together, she was able to have an informed conversation about estrogen alone therapy that simply hadn't happened before. Tonight's action item isn't medical, it's a question. If you've had a hysterectomy, find out whether your prior hormone conversations ever distinguished between estrogen alone and combined therapy, because those are two different risk profiles wearing the same public reputation. This connects directly back to timing from item 5, because the estrogen alone benefit was clearest in the same 50 to 59 age window, where the overall risk profile looked best. If nobody ever explained to you that hormone therapy isn't one single risk category, but several different formulations, each with their own evidence base, tap subscribe, because that's exactly the kind of nuance this channel exists to walk through every week for free. Hit like if you're realizing right now that a decision you made years ago was based on an incomplete picture. And if you know a woman navigating menopause who was told hormones are simply off the table forever, send her this video today. So far, you've learned that the 2002 finding was real but incomplete, and that estrogen alone and estrogen with progestin are not the same conversation. You could stop the video right here and walk into your next appointment better informed than most people ever get. But item 2 is the piece of this story that actually convinced skeptical researchers to revisit their own conclusions, a pattern in the data tied to something called the timing hypothesis. And it's not a theory anymore, it's reshaping how the Menopause Society writes its official guidance today. Number 3. Most people believe hormone therapy is primarily prescribed to prevent long-term disease, heart disease, osteoporosis, dementia. That belief is actually backwards from where the strongest evidence sits today. Major medical societies, following the WHI reanalyses, moved away from recommending hormone therapy for chronic disease prevention and instead reaffirmed it specifically for short-term treatment of vasomotor symptoms, hot flashes, and night sweats in recently menopausal women. That's not a smaller use case dressed up as a big one. Symptom relief was and remains one of the best supported uses of hormone therapy in the entire research record. Researchers found the size of that symptom relief effect large enough that it reshaped clinical guidelines, even while the disease prevention question stayed unresolved. Picture two different reasons to fix a leaking roof. One is to stop water damaging your ceiling right now. The other is to prevent your whole house from someday collapsing. The evidence for hormone therapy is strongest for the leak happening right now, the hot flashes and sleep disruption in front of you, and much murkier for the long-term structural question. This distinction matters for aging bodies specifically because of anabolic resistance and inflammation that build gradually after menopause Estrogen loss contributes to a low-grade inflammatory state that worsens with time since menopause, which is part of why starting closer to that transition, when inflammation is lower, tends to produce a cleaner symptom response than starting a decade or two later. Consider a patient, let's call her Josephine, 51, a hospital administrator who had gone 18 months without a full night's sleep because of night sweats. She'd been told by a previous provider that hormones weren't worth the risk for something as minor as sleep disruption. When she and her doctor looked at the actual evidence base, they found that vasomotor symptom relief is one of the most consistently reproduced findings in the entire menopause literature. And within a few months of starting low-dose therapy, her sleep tracked simply by how many nights per week she woke up drenched went from most nights to almost none. Tonight's practical step: keep a simple log for the next week of exactly when your symptoms flare, morning, midday, night, because that pattern is the actual clinical information a provider needs to have a meaningful conversation about symptom-focused therapy rather than a vague, "I don't feel like myself." Pair this with the risk factor list from item 5, because symptom benefit and cardiovascular risk are evaluated together, not as separate questions. Number 2. This is the finding that took the disagreement out of the room for a lot of researchers who'd spent years arguing past each other. It's called the timing hypothesis, and it isn't a hunch, it's now backed by follow-up data spanning more than a decade. The core finding: women who start hormone therapy within 10 years of menopause onset or before age 60 show a meaningfully different cardiovascular risk profile than women who start more than 20 years past menopause. In the WHI's own subgroup data, coronary heart disease risk tended to go down in the younger, closer to menopause group, while it went up in the group that started therapy decades after the transition. Researchers went back to the same data set that produced the 2002 scare, split it by time since menopause, and found two almost opposite stories sitting inside one average. Think of it like judging a garden's response to fertilizer by mixing soil samples from a garden planted this spring with soil from one that's been fallow for 20 years. Average the two together, and you'll conclude fertilizer does nothing, when really it does two very different things depending on the soil's condition going in. This lines up directly with mitochondrial and vascular aging, the biological reality that arterial tissue's ability to respond favorably to estrogen appears to decline the longer it's gone without it, a window of opportunity that most patients and even many prescribers were never told existed. Consider a patient, let's call her Patrice, 52, a nurse herself who'd assumed her own professional caution around hormones was simply the safe, informed choice. When she finally reviewed the age-stratified data with her physician, she realized she was sitting squarely inside the window the timing hypothesis identifies as most favorable, and that continuing to avoid the conversation based on 2002-era headlines meant potentially missing a window that narrows with each year. Her actual decision afterward is hers to make with her own doctor, but the conversation itself only happened because she understood the age-based nuance existed at all. Tonight's step: if you are within roughly 10 years of your final period, write that date down and bring the timing hypothesis by name into your next appointment. Naming it directly changes the conversation, because not every provider proactively raises it. This connects to item 3, because the same early window that favors cardiovascular benefit is also when vasomotor symptoms are typically most severe, meaning the group most likely to benefit is often also the group most motivated to ask. The next piece of this story is the part almost nobody expects, because it isn't about estrogen's risks at all. It's about how breast cancer risk plays out differently, depending on whether progestin is part of the formula, a distinction that quietly split researchers into two camps for years. Number 1. Here is the finding that most surprises people because it runs against the entire hormones cause cancer narrative that took hold after 2002. In the WHI's own randomized trial, estrogen alone therapy used by women who'd had a hysterectomy was associated with a decreased risk of breast cancer incidence and mortality, a finding that has held up through long-term follow-up. Estrogen plus progestin, by contrast, was associated with an increased risk that persisted for 2 decades after the trial ended. This is not a small footnote. It's a genuinely counterintuitive result that researchers themselves have spent years trying to fully explain, and it means hormone therapy causes breast cancer was never an accurate summary of the data. One specific combination increases risk, while estrogen alone in a specific population appears protective is the accurate version, and it's far less quotable, which is probably part of why it never became the headline. Picture 2 keys that look nearly identical but open completely different locks for years. The public was handed one label, hormones, for 2 mechanisms that behave in opposite directions inside breast tissue. The reason this connects to aging physiology comes back to inflammation and cellular repair capacity. Progestin's effect on breast tissue proliferation appears to interact differently with estrogen than estrogen does alone, and that interaction seems to matter more the longer breast tissue has been estrogen deprived, tying this directly back to the same timing window from item 2. Consider a patient, let's call her Yvonne, 56, who'd avoided any hormone conversation for a decade specifically out of fear of breast cancer, a fear she said her mother had passed down to her after reading about the 2002 study. When her doctor walked her through the fact that she'd had a hysterectomy and therefore was a candidate for estrogen alone therapy, the specific arm of the trial associated with lower breast cancer risk, not higher, the entire framework she'd been operating under for 10 years shifted. Tonight's action. If breast cancer risk is the reason you've avoided this conversation, find out specifically whether you'd be a candidate for estrogen alone or combined therapy, because those are, again, 2 different risk stories being told under one name. Pair this finding with your mammography history, since regular screening is what makes any of these risk numbers actionable rather than abstract. What we covered today isn't really about hot flashes or lab values, though both matter. It's about not spending another decade in unnecessary discomfort or avoiding a conversation with your doctor because of a headline from 2002 that never told the whole story. The research since then hasn't reversed that original finding, it's completed it, adding the age, timing, and formulation details that were missing the first time around. Tonight, write down the date of your last menstrual period or the year you went through menopause. Write down whether you've had a hysterectomy. Write down your last cholesterol and blood pressure readings if you know them, and the date of your last mammogram. Bring the phrase timing hypothesis into your next appointment by name. And if you're currently avoiding hormone therapy purely out of general fear rather than a specific documented risk factor, book a conversation with your doctor about which category, if any, actually applies to you. If you have a personal or family history of breast cancer, blood clots, or unexplained vaginal bleeding, talk with your doctor before considering any form of hormone therapy. Those specific histories change the risk calculation independent of your age or timing. A lot of you are going to walk away from this wondering exactly what a low-dose or transdermal option even means compared to a pill, because formulation and delivery method turn out to matter almost as much as timing does. I've got a video breaking down exactly how the patch, the pill, and the gel differ in how they move through your body. I'll link it right here. Have you had a conversation with your doctor about hormone therapy that felt incomplete or left you with more questions than answers? Tell me about it in the comments. Your experience might be exactly what someone else watching this right now needs to hear.